Hello, everyone. First, I would like to thank the organizers for inviting me to participate in this e-learning module and to participate in this lecture that I will talk about toxicity and management strategies for adverse events related to endocrine therapy for patients with advanced hormone receptor positive breast cancer. My name is Maria Alice Franzoy. I'm a medical oncologist and researcher at Gustavo Roussy in France. These are my disclosures. And the first point that I would like to make is that we have evolved a lot in the treatment of advanced breast cancer, and more even so in the treatment of hormone receptor positive advanced breast cancer. We have data that show us now for the first time that the median overall survival surpasses the 5 years. This means that voy a recomeçar.
Perfecto, no hay ningún problema.
No, voy a colocar porque no había cronómetro.
Ok, perfecto, pero tranquila, no hay ningún problema con el tiempo. Lo que necesites hacerlo. Te cuento de nuevo. Uno. ¿Tienes la diapositiva primera?
Ouais.
Ok, en 1, 2 y 3.
Hello, everyone. First of all, I would like to thank the organizers for inviting me to participate in this e-cancer e-learning course, in which I will talk about toxicity and management strategies for adverse events related to endocrine therapy for patients with advanced hormone receptor positive breast cancer. I am Maria Alice Franzoy. I'm a medical oncologist and researcher at Gustavo Roussy in France. These are my disclosures. And the first point that I would like to highlight is that we have done incredible progress in the treatment of advanced breast cancer, and more so in the treatment of hormone receptor positive advanced breast cancer. We have data that show us now that the median overall survival for those patients surpasses 5 years, thanks to a better understanding of the biology of the disease and the availability of new agents to treat this disease. This means that metastatic hormone receptor positive breast cancer is becoming a chronic disease. If we look in that optic, this also means that the majority of patients will stay a long time under treatment with endocrine therapy agents, which are the standard of care in first line and second line in combination with target agents. So we have the standard of care line, which is endocrine therapy and a CDK4 and 6 inhibitors. And we know that these patients will use this regimen for a long time. The median progression-free survival with these agents is around 24 months. This also means it's great news, but it means that these patients will face and will live with persistent low-grade adverse events. And of course, we are talking about different side effects and adverse events than when we talk about chemotherapy. But we have data that shows us that endocrine therapy is not without side effects. And moreover, if we look in the early setting, which is where most of the data on adverse events of endocrine therapy is located, we can see a bunch of side effects that are related with the use of these agents, and moreover, that they have an impact in quality of life, meaning that endocrine therapy is related with a decreased quality of life, even more pronounced than the use of chemotherapy in some patients. This is all in the early setting. What type of side effects are we talking about? So the most common side effects related with endocrine therapy agents are musculoskeletal symptoms, vasomotor symptoms such as hot flashes, sexual dysfunction, vulvovaginal symptoms, fatigue, insomnia. We can have also cognitive impairment and in the presence of aromatase inhibitors, we have bone loss, which may lead to fractures. Of course, in the context of metastatic breast cancer, most of the patients will present also with bone metastasis, the vast majority. So they will already be receiving bone modifying agents and will be protected by these side effects, but it's important to say. We also have more rare side effects, such as thromboembolic events and endometrial cancer related to the use of tamoxifen. In the early setting, we have, so this slide is quite nice because it illustrates the main side effects, and the prevalence here is the prevalence that we see in patients that are doing adjuvant endocrine therapy. But what is the prevalence in the presence of metastatic disease? So here what I did is that I picked up the side effects related to endocrine therapy in the main trials of the combination of endocrine therapy and CDK4 and 6 inhibitors. And why did I do this? Because it is now the standard of care, so it's better that we look together. We can see that in comparison with what we saw before of around 40-45% of hot flashes, in the metastatic disease, we are talking about 13%. Fatigue, which was 40%, we see here 30%, arthralgia 24%, we also see rates of alopecia, urinary tract infection, which may be related to vulvovaginal symptoms, but we kind of notice that the prevalence is a bit lower than when comparing to the early setting. But is it a matter of lower prevalence, or is it a matter that we are assessing less these side effects? So here I would like to show you a study that is quite interesting. It's a more ancient study, but what they did is that they asked patients to self-report their symptoms, so patient-reported outcomes, about main side effects, and they exposed the main side effects of endocrine therapy, and they compared the prevalence of these side effects when was self-reported versus what was seen in the main clinical trials. And what we see is that when patients self-report their symptoms, they reveal way more symptoms than what we see in clinical trials. For example, hot flashes, more than 50% of the patients self-reported. The same for almost 25% for vaginal dryness, fatigue in 49%, mood swings in 16%. So it may be that the problem is that we don't communicate so well, and it may be that we neglect a bit this type of side effects because we as oncologists, we are very used with heavy side effects of chemotherapy, and we are very used to treat nausea, vomiting, infections, mucositis, and these other type of side effects are things that we are less sensitive to assess and treat. So how can we mitigate side effects of endocrine therapy? Well, the first step to mitigate a symptom is ask and assess the symptom. And here I would like to illustrate that what we think may be fine by us as a doctor is not necessarily the same as the patient has experienced. We have data that show us that physicians and patients don't frequently agree in the grade and the severity of a side effect. So a physician may think that an adverse event is less severe than what the patient feels. And also, it may happen that physician misses some side effects when we ask physician if the patient has, and when we ask the patient if the patient is feeling the side effect, there is a chance that the physician misses the symptom because we don't ask so much. And here, quite interesting in the context of metastatic breast cancer in patients receiving endocrine therapy, we have data showing that the perception of the distress is different in patients and physicians. For example, For fatigue, here represented by lethargy and sleepiness, we have quite a difference in the perception of distress by the patient and the physician. Same for weight gain, vaginal bleeding, hot flashes is almost the same. However, when we go to the next graph, we see the rate of that the patients will consider to ask for a change in their therapy because of a side effect, and the rate that the physician would consider change the therapy because of the side effect. So we see that a lot of patients, because of hot flashes, would consider changing their treatment because it bothers them so much. But for the physician, we have the perspective that is not that important. The same for fatigue, the same for weight gain. So this is all to mean to give you the message that these effects, side effects, although of low grade, they have an impact on quality of life. They bother our patients, and we will only be able to treat them if we ask our patients about these side effects. So a simple question: most patients under endocrine therapy report hot flashes. Are you facing those symptoms? Are you having trouble sleeping? Are you facing any sexual difficulties? Are things that we need to be more sensitive to talk about it with our patients. And this, after we assess the symptom, the second step is to act. So we have data now showing that it's a growing field of research, symptom management, and we have several available options, including pharmacological and non-pharmacological strategies to treat the main side effects of of endocrine therapy. This was an exercise that we did in the early setting, but because most of these trials were done in the context of adjuvant endocrine therapy, but in terms of symptom management are things that we can also bring to and try to use it in patients with metastatic disease. And we're going to look each one in more details. So the first one is musculoskeletal symptoms. They are quite frequent and bothersome in the presence, both in tamoxifen, fulvestrant, but more pronounced in aromatase inhibitors. One thing that we can try to do is switch between aromatase inhibitors. Is something that was shown to decrease the degree of pain and increase tolerability of treatment in patients with adjuvant endocrine therapy. So it's something that can be tried in patients with metastatic disease. Other things that are highly effective is physical activity and acupuncture. We have data showing that those are effective management strategies. For patients that have also pain-related arthralgia, duloxetine may also be used. And things that we know that it didn't work so well was glucosamine, chondroitin, omega-3 fatty acids. So I think that we need to also see and think of what's not effective. So as effective strategies, physical activity, acupuncture, and duloxetine, and switching to another type of aromatase inhibitors may be an option. Yoga, we also have small studies with encouraging results, but the evidence is a bit lower. So about hot flashes, which is it's a very common adverse event, mainly by the use of tamoxifen. We have several data showing that pharmacological options such as antidepressants are highly effective in controlling hot flashes, and they can reduce the rate of hot flashes by 60%. Most of the data comes in with venlafaxine. And what we know also is that if we increase the dose of venlafaxine, we increase the efficacy in symptom management, but also we increase the rate of side effects such as mouth dryness, decreased appetite, nausea, and constipation. So the idea is always to start with the lower dose. We also have data with other type of antidepressants, such as escitalopram, sertraline. They are all effective in reducing hot flashes. We need to be cautious when we use selective serotonin reuptake inhibitors, because they may interact with tamoxifen because they inhibit CYP2D6. However, this is something really preclinical, and we have now more recent data showing that it may not be such a big problem. So it's a controversial topic, but if we can choose antidepressant, we can perhaps use vaccine that is the most known and studied agent. We also have data with anticonvulsivants that are quite effective, such as gabapentin, pregabalin, and another pharmacological agent that was very used a long time ago was clonidine. Now we don't use it as a first option because of side effects such as hypotension, dry mouth, dry eyes, dizziness, tiredness. So it's not such an option for first-line treatment. We have interesting data with oxybutynin, which it's highly effective also in reducing hot flashes, but we need to keep attention on side effects of these drugs. And the key message here is that there is not a standard choice for pharmacological therapy. Pharmacological therapy for hot flashes needs to be a shared decision. So these drugs are effective, but they have side effects. So we need to balance this with the patient, and always start with a lower dose and increase slowly and evaluate response. But if we don't want to use drugs to treat hot flashes, we also have options to offer our patient of non-pharmacological options. We have data showing that cognitive behavioral therapy may work and hypnosis also may work. These are all data from randomized controlled trials. Of course, they are not very big, but they show an important reduction in the severity of this symptom. Is not the number of hot flashes per se, but the severity and how women are bothered by hot flashes. So in summary, we have pharmacological options that are effective. We have non-pharmacological options that are effective. Is one of the most common side effects in patients under endocrine therapy, especially patients that were premenopausal and become in a menopausal status because of the treatment. So we need to assess and treat it. Another point that I would like to make is about sexual dysfunction. And here, just to introduce the topic, we need to think that sexual dysfunction is not only the absence of physical disease per se, but it also involves a psychosocial context and a cultural context. So it may manifest by vaginal symptoms, but also changes in libido, desire, body image, couple dysfunction, depression, and anxiety. What are the risks? The risk factors highly known for sexual dysfunction is a prior history of already sexual problems, the presence of depression and anxiety, patients at a young age. But we need to be attentive to not exclude elderly patients of sexual health assessment. Actually, what guidelines recommend is that we proactively ask our patients about their sexual life in several encounters, because although most of the women don't receive any type of counseling about sexual health, most of them, when we are asked, they would like to have received, and they believe that this initiative needs to come from the doctor. So we know there is a taboo and a hard topic to discuss, but there are strategies that may facilitate this discussion, having checklists, auto questionnaires, and informative material in the waiting room may help. We have specific articles specifically on communicating strategies around sexual health. And it's important that ideally, if we can assess, we should refer these patients to a multidisciplinary dedicated team to proper address these symptoms. So about vaginal issues, we know that vulvovaginal symptoms such as vaginal dryness and vaginal atrophy are very common in patients using endocrine therapy, and we should know that one thing that we can easily offer to all patients is the use of vaginal lubricants, because they improve the vaginal symptoms, pain, discomfort, and they are easily accessible. We have data from randomized controlled trials showing its efficacy. For patients presenting dyspareunia and pain during sexual intercourse due to insertional pain, one option that was tested in a clinical trial was the use of lidocaine 4% in the vaginal vestibules, and was associated with increased arousal, desire, and sexual pleasure. However, before starting this intervention, I would recommend that the patient is seen by a gynecologist in order to exclude other diagnoses such as vaginismus or pelvic contraction that we need to correct. So if we continue talking about vaginal issues, we know that there's a lot of controversy and polemic about the use of local estrogens, vaginal estrogens. We all know that these are very effective agents, but we also know that there is a risk of systemic absorption with these agents. So we don't recommend them never as a first-line treatment, but as an option for temporary use and very low dose use in those patients with refractory symptoms, okay? What about the use of vaginal laser? Vaginal laser seems to be very effective when we look in data in prospective or single institutional studies. However, we have one negative randomized clinical trial and one negative meta-analysis, so inconclusive, about its efficacy. So we cannot recommend with such strength this intervention, and there are several ongoing studies that will better shed light in the efficacy of this intervention. And what about sexual dysfunction beyond vaginal issues? So we know that our patients are at risk of facing libido, low libido, lack of desire, anxiety, depression, difficult couples relationship, and we know that psychoeducation and cognitive behavioral therapy may help, can help our patients better deal with this. So this can be delivered individual or in couple, in group, in person, or even technology delivered. And we have data for that, mainly again in the early setting, but we have encouraged data for that. Another side effect that I would like to talk to you about is endocrine therapy-induced alopecia. Here we are talking to a different type of about a different type of alopecia. There's nothing to do with chemotherapy-related alopecia. It seems quite as what we have with androgenetic alopecia. So it is located mainly in the scalp. Patients usually start noticing this side effect more pronounced around after 6 months of therapy, and the incidence in clinical trials is about 4.4%, but when we ask our patients, when patients self-report, it can go up to 31, 32%. And also we have data showing that this may be more intense with the use of CDK4 and 6 inhibitors also. So there is data showing that the minoxidil 5% topic may help these patients, so it's something to consider. Endocrine therapy may also increase sleep disturbances, so we can all recommend sleep hygiene to our patients. So, and also to treat the contributing factors may be related to the presence of hot flashes, pain, anxiety, and specific strategies may work, such as the use of cognitive behavioral therapy, and if needed, pharmacological strategies as a second step in avoiding benzodiazepines, but using hypnotic for limited time. And what about cancer-related fatigue? So endocrine therapy is associated with cancer-related fatigue. And here we are talking about a type of fatigue that is different than a normal fatigue. It's a fatigue that is not relieved by rest. It's strongly correlated with depression, sleep disturbance, pain, cognitive complaints. And we don't have a medication with a well-known efficacy to treat these symptoms. We have some data, mixed data about ginseng, but all the other supplements and things that were studied did not show to be effective in reducing cancer-related fatigue. However, we have data showing that physical and psychosocial interventions can help patients better deal with fatigue. And here I would highly cite physical activity. So physical activity, although counterintuitive, really helps patients reducing cancer-related fatigue, has other benefits also in quality of life, and should be encouraged. Psychosocial interventions such as psychoeducation, cognitive behavioral therapy, and mindfulness-based stress reduction can also relieve cancer-related fatigue. And what about recommended physical activity, which is effective for several of these symptoms for patients with bone metastasis in the context of metastatic breast cancer? So this was we had less literature about this before, but what we know is that new data shows that it's feasible to perform a physical activity in the presence of bone metastasis, that physical activity should not be discouraged in these patients, but just carefully assess it. So we have a consensus recommendation now that if the patient doesn't have a lesion at risk, so we need to carefully look the sites of bone metastasis, discuss the case with the patient, and these patients can, yes, perform physical activity, ideally adaptive physical activity in the presence of a supervisor that can adequately coach our patients. So in conclusions, I would like to rephrase that advanced hormone receptor positive breast cancer has turned to a chronic disease. These patients will be exposed to endocrine therapy and target agents for a long time with a minimum median of 24 months. Endocrine therapy use is associated with adverse events that, although they may be less common in the metastatic setting, they can also interfere in quality of life. Just to mention a few, we can say about hot flashes, musculoskeletal symptoms, vulvovaginal dryness, fatigue, insomnia, and androgenetic alopecia. We have several validated pharmacological and non-pharmacological strategies to treat and alleviate these symptoms, but this will only be possible if we as doctors, we perform a proactive and individualized approach. We ask our patients, we perform a correct symptom assessment, and then we can refer to symptom management to improve quality of life while on endocrine therapy. I would like to thank you for your attention. Don't hesitate to send me questions if needed. And I would also like to acknowledge the help of my colleague, Inês Vaz Luiz and Antonio de Meglio, while preparing this presentation. Thank you.